I'm Brian Grimberg, Assistant Professor of International Health and the head of the IDI lecture series. On behalf of myself and the chair of IDI Institute, Dr. Salata, I want to welcome you. The IDI Institute was set up to help foster collaborations across departments within the School of Medicine, such as the Center for Global Health, Pathology, and Infectious Diseases, along with the schools of Dental Medicine, Arts and Sciences, and Nursing. In addition to funding pilot studies, we also host these lectures to bring together these multidisciplinary teams to discuss health challenges throughout the world. To describe this semester's lecture, I'd like to introduce Dean Pamela Davis.
Thank you, Brian, and good afternoon. I'm pleased that so many of you are here today to learn from a true expert in the field about a topic that turns out to be more timely every day. As many of you know, our School of Medicine is dedicated not only to advancing medicine, but also to responding to medical crises that arise locally, nationally, or globally. Through our Center for Global Health and Diseases, we are strategically positioned to link international health resources with our affiliated institutions in a multidisciplinary program of research, training, and clinical application related to global health. International health research has been a strength of Case Western Reserve since the Center for Global Health and Diseases inception in 1987, originally as a Center for International Health. With a mission to promote health in the world and enrich our community, the center is fortunate to rely on the expertise of the scientists who helped define this field of academics as it emerged over the last 3 decades. It originated with a former dean, Fred Robbins, and that tradition is now carried on by its current director, Dr. Jim Kazura. Most significantly, Universities Allied for Essential Medicines recently ranked Case Western Reserve University as #1 in global health research universities in the United States. Speaking to us today with a frontline perspective on the current Ebola virus outbreak and crisis is Dr. Daniel Bausch, an associate professor at the Tulane University Health Sciences Center. Dr. Bausch serves in both the Department of Tropical Medicine section of infectious diseases as well as the Department of Internal Medicine. In addition to his medical degree, Dr. Bausch has a Master's of Public Health in Tropical Medicine. Currently, he's serving as secondman to the U.S. Naval Medical Research Unit No. 6 in Lima, Peru, where he is the head of the Virology and Emerging Infections Department. He specializes in the research and control of emerging tropical viruses. Previously, Dr. Bausch has worked with the CDC's Special Pathogens Branch, where he gained extensive experience with sub-Saharan Africa, Latin America, and Asia combating pathogens such as Ebola and Lassa virus, hantavirus, and SARS coronavirus. This position uniquely suits him to speak to epidemics such as this one. He serves as a frequent consultant for the World Health Organization, the United Nations, the National Institutes of Health. Dr. Bausch recently returned from Guinea and Sierra Leone, where he worked with the World Health Organization to arrange and provide clinical care to patients afflicted with the Ebola virus. He is presently collaborating with the World Health Organization and other groups to explore the possible use of experimental therapies and vaccines in response to the ongoing Ebola virus outbreak, as well as contributing to preparedness training for clinicians, both in West Africa and the United States. Dr. Bausch places a strong emphasis on capacity building in all of his projects, and also has a keen interest in the role of the scientist in promoting health and human rights. With more than 100 peer-reviewed publications and book chapters to his name, Dr. Bausch is also a member of various WHO working groups and has been honored by the U.S. government multiple times for his service in public health, both here and abroad. Ladies and gentlemen, please welcome Dr. Daniel Bausch.
Thank you very much. Thank you for having me and all the people who've organized this and for you to coming. As the dean said, I recently got back from Sierra Leone and Guinea, but not so recently that anyone here needs to worry. So I just wanted to put that out there right in the beginning. I think, am I controlling the slides? Yeah. So, if I was giving this talk about a month ago, we really just talked all about West Africa. And now we'll change things a little bit because this has come home, and for you guys in the last few days, it's really come home, at least sort of conceptually. And so I think there's probably a little bit different way of looking at this now than you might have last week or last month. So I'll try and touch upon some of those points. This is the routine disclaimer that no one likes to read. But I'm going to jump ahead a little bit to just give you this, because this is important to recognize. And I apologize if this is repetition or something that you already know, but these are important points because there's so many things that are being said right now in the press, especially lately, and of course here in Cleveland with recent events. So this is important to recognize to start with. How is Ebola virus? How do you get this thing? And so you get Ebola virus with the exposure to bodily fluids of a person who's sick with this disease. We know very well from lots of research, if you're not sick, you can't transmit this virus. It's very clear that the virus load in a person correlates very well with how sick they are. And even more than the question of whether they've started to have disease or not, it's how sick they are. It's not spread through the air, despite some of the things that you may have read in a little bit of a debate that's out there right now. I think it's very clear that this virus is not spread through the air, at least not through true aerosols, that you could, for example, just, if I were infected with Ebola, that you could get it from just breathing the same air. That's a little bit different from those of you who know about contact precautions and droplets. Like if I were to cough and someone who's within a meter or so and a small droplet from that cough lands on the mucous membranes of their eyes, that could infect a person. But this is not a virus that just spread casually through the air. It's not a virus that spread casually at all. It's a virus that spread with close contact bodily fluids. It's when people have diarrhea, vomiting, bleeding, which are usually in the later stages of the illness. We make an accurate but perhaps a little bit of a misleading determination whether someone is symptomatic or not. And really it's not so much whether they're symptomatic, it's at what phase of symptoms they're at. And so a person, I've been back from West Africa for 6 or 7 weeks now, so this is all just an example, right? Don't worry, the longest incubation period for this virus is 21 days, and most periods in most situations is actually significantly shorter than that, 8 to 10 days. But even if you were in sort of a worst case scenario where I was sick and I was incubating the virus, no risk, and in the first few phases I'm going to start with fever and headache and things like that. And you don't start with diarrhea, nausea, vomiting the first day of illness. That comes in at day 3, 4, like that. And so that's when a person is very sick, when they're shedding high levels of a very infectious virus into the environment through the vomiting, through the diarrhea, through the bleeding, and that's when we have to worry about those sorts of contacts where really this virus is shed. So I want to a little bit give you guys the facts, but it's also my job to hopefully put you at ease, and I don't want to minimize the risk that this does pose primarily to people in West Africa, a little bit to people in the United States, but we need to keep this science-based. And one of the things that's very difficult about this, and one of the things that I spend a lot of time doing, is going around and kind of demystifying this whole situation. Ebola is a dangerous virus, but it's a virus. It's not something from a book. It's not something from a movie. It has scientific principles, and we need to remember that and kind of keep that in mind when we see what's going on in our society. So I wanted to jump to that. Again, it's not from casual contacts, it's not from shaking hands from somebody, it's not from breathing the same air, it's from taking care of someone who's really sick. And so if we look at who gets this virus, it's the sorts of people who have those direct contacts. So it's a family member taking care of someone who's really sick in the household. And then, of course, of particular interest to this group, it can be a healthcare worker who's taking care of someone who, again, is really sick if they don't have the proper precautions. And that obviously will be of particular interest to all of you. It's not from, as I mentioned, it's not from passing the room of somebody who was sick, even if they did have Ebola. It's not from passing them in the street. It's not from just shaking hands during the incubation period. It's direct contact. This virus is not something that we really see and food that's going to be imported, and I'll touch upon that again in a minute. The early symptoms, as I mentioned, and this is sort of the good news and the bad news. The good news, as I mentioned, is when someone first falls sick with fever and headache, they're not very infectious, and so that's not really the key period that we're so worried about. The bad news, of course, is we'd all like to have something where we could easily say, aha, that's a person who has Ebola, and we can recognize that right away, and we can use the appropriate PPE or personal protective equipment. We can isolate that person, and we'll know, everybody easily say, that's Ebola, that's not. That's the hard part, because again, people present with fever, headache, and then progress after a few days of with nausea and vomiting and diarrhea, and things, of course, that we've all had, and and with other illnesses that are much more common in West Africa, much more common in the United States, and again, difficult to distinguish. So that's our challenge to try to deal with that situation. 21 days, the incubation period, as I mentioned, usually much shorter. So I'm going to go back. I wanted to get those facts out because I think they're important for you to be able to interpret a little bit and digest the information that I'm going to give you, which is now really going back to how we got here, what happened in West Africa, how did we get to this point where we have thousands of cases of Ebola in West Africa, where we have some imported cases, and to some degree getting my crystal ball out and telling you what will and what will not happen next in some of these areas. Again, I don't guarantee any particular degree of precision on that, but I'll do my best. So I'll give you an idea of the reality on the ground and what we're doing, and a little bit some of the pertinent scientific questions that need to be answered to be able to combat this in coming months. Don't you hate when you go to talk with people, just read the slides? I always hated that. I was just, send me the slides if you're going to do that. So I'm going to take it for granted that you can all read. We just heard that CASE was the #1 global health research. Some of my colleagues at Tulane might not agree with that, but I'm going to let that go. So as I said to someone earlier, you guys are paying for the hotel. So the important things, just a few points here. So these are acute infections, and I'll get calls and say someone came. We have this patient who came from the Congo or whatever, and they've had a fever for 4 weeks, and right away, stop, not viral hemorrhagic fever, because if they've had a fever for 4 weeks, that's too long. These are acute infections. 21 days, the longest incubation period, usually 8 to 10 days. We use 21 to be conservative because not everyone knows when their last contact was, and so that can be difficult. But important to recognize there's no chronic form of this. There's a few exceptions of the virus can be maintained in the semen and males for a while after. But for the most part, somebody gets Ebola, they get sick, they get better. Once they get better, they're better if they survive, and that's the end of it. And then a couple other key points. It is, I think, a common misconception that now has probably already been corrected for this group, but people don't die in Ebola because they exsanguinate. They don't lose all their blood. In fact, a minority of patients even have any bleeding that we see, maybe 20, 30%, depending upon the given outbreak and the given species of Ebola virus. So what people are dying from here is shock and multi-organ system failure. I don't know, most of this group is probably fairly medically attuned and realizes a little bit what the physiology of that is, but that's what's going on. We won't go into a lot of detail here about this, but recognize that again, it's not just people losing all their blood. There are other things going on in systemic inflammatory response syndrome and septic shock and organ system failure. The key point of this slide is that these viruses are lipid enveloped, and for those of you who are not familiar with virology, the key message there is lipid envelopes are very easy to disrupt. And so our problem with this virus is not that it's kind of an Andromeda strain thing that persists in the environment. We don't have a big issue in terms of the virus, for example, that's leaking out into the groundwater in West Africa and infecting people that way. It's not something that persists very long. Depending upon the environmental conditions and how much light and heat there is, this virus will persist for hours to days in the environment. Not very long. For example, in a corpse, in a decomposing body, the pH changes and other things would probably not be conducive to any viral survival for a long period of time. So we do have environmental problems in the sense that if I'm a sick patient, of course, and I had vomiting and the table is contaminated and someone comes along right after that and touches the table and then touches their eye, obviously that can be an infectious event. But we don't have a problem that the fluid is going to seep into the groundwater and persist for a long period of time. It's really, again, those much more direct contacts between patients, between sick people, is our challenge. As I'm sure you all know, this is a member of the filovirus family. Philo means thread. Thread comes obviously from this appearance of the virus that looks long and thin like that, like a thread. And we have two different genera here, Marburg virus and Ebola. And within Ebola virus, there are various different species. They're all associated with fairly consistent case fatality ratios, Zaire being the most dangerous of the viruses, which is usually associated with something on the 60, 70, 80% case fatality ratio, and then Sudan in the 50, 60, in the 50, 60%. Cote d'Ivoire, there's only been one case of Cote d'Ivoire recognized, and that person survived, so I guess the case fatality is 0, although I wouldn't volunteer to be in a control group for a study necessarily. Bundibugyo is around the 35%, and Reston appears not to be a human pathogen for all we can get. And there's a lot of interesting epidemiology and epizoology around these viruses, but we won't go into those details. But this is the one that's currently our problem in West Africa, and the one, of course, that's resulted in an imported case and 2 secondary cases in the United States. Incidentally, you'll see in the literature and in the news a lot of varied case fatality rates, and so some people say, well, it's 70%, in some places it's 45%, and a lot of that has to do with some of the surveillance and the case finding, and so one center in one area of a country where they have really good surveillance and they're going out and getting all the cases from the community and able to bring them into an isolation and treatment center, they may have one number, and a different place where the surveillance isn't very good or the population is not very interested in coming in and getting counted, so then you might have, for example, people who are very sick but die at home, and if they die at home, of course, they don't get counted in the denominator. So there's a lot of, there can be some biology in terms of host response, other aspects that we don't fully understand in terms of the mode of infection or the inoculum of infection, whether you got a few viruses or 1,000 viruses, but there's a lot of that really is related more to the epidemiology and the surveillance rather than the virus itself. We're pretty sure that this virus is maintained in types of fruit bats. I say we're pretty sure because we've actually never grown Ebola virus from a fruit bat. We've grown Marburg virus from a fruit bat. And so that the ecology of that is fairly well described, and I think very indicative that they indeed are the reservoirs. We've had PCR positives from 3 different species of fruit bat, and I think we feel relatively confident that's what's going on here. This is actually a shot into a mine in the Democratic Republic of the Congo in an era where we were less sure what the reservoir was for this virus. And so after we would kind of get the human aspects settled, we'd go out and start trapping animals and looking at different things, and sort of where my family gave up trying to understand what I do for a living as well. But these are all bat eyes looking back at you in this mine in the DRC. So. And this is what we believe happens. And so we have a bat that is infected but not symptomatic, as is essentially the definition of a reservoir. And so the bat, usually unbeknownst to the person, can directly infect the person. It's not like the rabies story of a bat bite or something like that. It's much more indirect, we think. And so these are fruit bats. They may be hanging around mangoes and mango trees and things like that, contaminate the mangoes, and then a person gets that mango and would get infected that way. Or they get infected indirectly. So maybe it's the chimp or the monkey that eats the mango. And then the human comes and hunts the chimp or the monkey, or hunts the bat, and that does happen in some areas of sub-Saharan Africa. And so they get infected indirectly It's not from eating the cooked product, because this virus, again, is killed pretty easily. So once you made your bat soup or your monkey soup or whatever and heated that up, you wouldn't have any viable virus in that. It's from the person who's butchering and preparing the meat that would be exposed. And so we have introductions in this way from the wild. And all our evidence from previous outbreaks, or at least most previous outbreaks, and as well as our evidence from this outbreak, it indicates that we have one or at least very few introductions from the wild, that these are very rare events, and then everything else that happens is human-to-human transmission. So if we have 8,000 confirmed cases of Ebola in West Africa, really the situation is that we had one introduction, and the other 7,999 were all between humans. And so whereas it might be good advice for many different reasons to maybe not go out and eat bats at this particular time, if anyone was contemplating, but nevertheless, that's really not how we're going to stop the outbreak. It's not about the bushmeats problem right now. It's about the human-to-human transmission. So here's how things went and are going in this area of sub-Saharan Africa, out here in the western coast, and an area where we had never seen this virus before. This Zaire Ebola virus had only been seen heretofore in the countries of Gabon and the Congo and the Democratic Republic of the Congo. And but if we looked retrospectively, last December of 2013, some cases of Ebola virus disease started to come to light here in an area called Gekidu in the southern part of this country of Guinea, a francophone country, former French colony. And this bounced around here for a while. And I was there in April. We had a situation which is not too unusual, where a healthcare worker got sick. And one of the things that happens in this situation is it'll start in a rural area typically, again with that bad introduction, and then people will go to a hospital. And ironically, that's really one of the big problems, is people get to a hospital. And so they get to a hospital in this area of the world. Note that these are essentially the poorest countries in the world. If you look on the United Nations Human Development Indices, Guinea, Sierra Leone, Liberia, these are countries that are occupying the ranks 187, 188, 189, that sort of thing, really low. And that's why this is happening there in the first place, because these countries don't have a developed public health infrastructure. They don't have a developed medical infrastructure. And so when this gets into those sorts of environments, then we really have a problem. And if we look at where these things get introduced, there are some interesting and still unknown aspects of the ecology and the biology and why a bat got to one place or how it got introduced. But after that, if we look at where we have a large outbreak of Ebola virus disease, we almost always know why that is, and that's because this happens in places where the infrastructure is really undeveloped in sub-Saharan Africa, usually as a result of many years of civil unrest or civil war, and that's what we've indeed had in Sierra Leone and Liberia, and to some degree in more recent years in Guinea as well. So this was bouncing around in this rural area. I'll show you some pictures in a minute. Got into a hospital and recognized that the hospitals may be places where there might be no running water, no soap, no clean needles, no gloves, and so you can imagine the infection control in that environment. And so you get healthcare workers who get infected. One of them thought that he would get a better treatment if he went to the capital of Guinea, which is the city of Conakry, about 1.5 million. And he stopped here to see some family and spent the night in Ebola and infected some people here, and then came here to Conakry, got into a much bigger hospital, but not a hospital that really had resources that were much more prepared than in Gekidu. And so that initiated a change of transmission in healthcare workers, who then go home, get sick, get taken care of by their family members, and then pass it on to other people in the community. So this kind of bounced around in Guinea, but when I was in Guinea in April and early May and coming home, we thought that, okay, maybe we had this controlled, and things were really we had just a couple cases in the isolation centers in those two places and thought maybe this is done. And I remember having discussions with people at WHO, do we really need to send more healthcare workers because there may not be anything for them to do, and kind of trying to figure out the right balance of getting people onto the ground but not wasting resources. And then the way this thing works is that you just can't have surveillance across broad swaths of a rural area of sub-Saharan Africa, very difficult to do. So sometimes you're right and everything is done, and sometimes you wait for a while, and then a few days later or 10 days later, somebody knocks on the door and tells you about a village 100 miles from there, where there are 10 people who recently died, and things, are flaring up again. And that indeed was the case, that this was flaring unbeknownst to us, compounded by this particular region where people cross easily and readily and frequently between the borders of Guinea, Sierra Leone, and Liberia. And this is an area where in many places in sub-Saharan Africa, people affiliate just as much with their ethnic affiliations as their national affiliations. And so different ethnic groups, they have the same language. They live on both sides of this border. Their village might be here, but on Wednesday, market day might be here. I've been around here where people lived on one side of the border and the kids went to school on the other side. Closing the border is not really an option. You can close the one road that passes, but you can just walk down a kilometer and pass through the brush. It's not really something that you could really close short of a major military operation. And so people were crossing back and forth here, and the disease was getting into Liberia and into eastern Sierra Leone, and then took off from there, and as you can see this map from a few days back, October 10th, where we have now a situation where there are at least one confirmed case of Ebola in almost all the districts of Liberia and Sierra Leone, and a large swath of Guinea as well. And in most of these districts here in Liberia, it's far more than one case, as you know.
I'd like to stop you right here and then ask a key question. Isn't this the scenario that can happen in this country, where people think they have the flu, they're working with patients, they go out, they infect people, everybody thinks it's flu, and there you got the propagation of the disease in this country?
So I think what I'm going to do is finish the talk, and we'll leave a few minutes for questions at the end. So this just gives you an idea of what the environment may look like here, or does look like here in Gekidu, and so you can get an idea, and I'm sure there's people here who spent some time in areas like this in sub-Saharan Africa, and many rich, positive cultural things about this area, but an area that's really been worn down from years of different problems and governance that's far from ideal. And so this is a picture, and I'm sorry for the graphic nature of it, but this is a picture of what I call hot zone Ebola, or if you've ever read Richard Preston's book, The Hot Zone. And this was what was described in that sort of literature. And when I first got in this field and read the literature, like the popular literature, and they talk about people with their eyeballs melting and their liver turning to mush, and I'd always think, why did it take so long to figure out what was going on with an outbreak? How many people did you need to see with their eyeballs melting to figure out that, it's Ebola? But of course, this is, whereas this exists, this is a much more typical presentation. You can see that this woman has a little bit of subconjunctival hemorrhage, a little bit of dried blood around the mucous membranes, attracting some flies. But even that is not the most typical presentation. The most typical presentation is, I would never take a picture of it because there's nothing to see. Person has a headache and a fever early on, and there's nothing really to indicate that they have Ebola in the early stages at least. So that again is our challenge. And so what do? We set up isolation wards. This is a picture of an isolation ward. The humanitarian organization, Médecins Sans Frontières, Doctors Without Borders, especially the group from Belgium, is one of the active players in this. This is set on the grounds of a hospital in Conakry, Guinea. You can't really see the care places are behind here, kind of underneath this tree, but we set up these wards, and of course we go in and we try and take care of people. This is not the inside of the ward. This is another ward of that ward that I just showed you. This is another one here in in a place called Kenema, Sierra Leone. And one of the issues that has been really difficult for us, and I think underlies what's happening here, is that we have just outstripped the resources of this outbreak. And very early on, partly because, of course, the countries themselves had no resources because they're the poorest countries in the world. And then when we sent the teams into Guinea in the early phases, it was a time when I would classify it kind of as a typical Ebola outbreak, if you will. And what I mean by that is you get into these sorts of settings, and then what will normally happen is that everyone will get together in the WHO office, the country office, and there'll be people from WHO headquarters and WHO country office and Médecins Sans Frontières and CDC and various different NGOs and, of course, the Ministry of Health. And you'll go around and there's an epi team that reports on how many cases there were last night, and a clinical team and a laboratory team and a social mobilization team and the communication team, and everyone will give the report, and then everyone will go out that day and act on things and then do it again the next morning, and in that way kind of get things cleaned up over time. And that's usually a very active group of maybe 30 or 40 people that are in that room, and each one of those just representative of their team, so lots of other people in the field. And when I was in Guinea in April, I thought, this is kind of the usual thing. And when I went back to Sierra Leone in June, a couple months later, when we recognized the outbreak was still going on and went to the WHO office, I kind of had the impression, like, where is everybody? And I think what had happened there is we really had just outstripped the resources. And so, contrary to popular belief, the organizations that deal with this, they don't have incredible resources to just deal with this for months and months and months and months and months. They have a few experts, some people that they can recruit. And so they get the people into the field, and after 3 or 4 months, we kind of expect to declare victory. And so finally, after 3 or 4 months, you have people, they're tired, they come home, and then when we say, I use a lot of analogies of like forest fires. You can't put out 99% of the fire. You have to get 100%. And so we come home perhaps thinking we got all of it, but there's 1% burning somewhere. And then when you finally notice, okay, that's raging over there, and then you say to everybody, okay, well, you need to go back. Well, you need to go back, but these people just came home. They're tired. We don't have the resources to replace them. We don't have necessarily the funds at that point to expect to send people back. We thought the forest fire was over. And so it's now we're struggling to catch up to say, okay, now we need to get back in. We know that this is raging now, and we need to get back in and recruit people and get more energy and get more funds in. And we've been trying to do that for recent months, but it's not been easy. And this is the result of this in some places. So MSF, for example, said, okay, we can put up a ward in some of these places where the outbreak is happening, but we just don't have the resources at this point to put them up everywhere. And so some of the other groups and local governments with WHO support were trying to do their best and put these things up, but they've been essentially dangerous places where we haven't been able to really protect healthcare workers. There have been healthcare workers that have gone on strike. We had an episode where the workers were on strike, unbeknownst to me and one other doctor from WHO who was there. We got geared up to go in and treat patients, and there were no other healthcare workers in there. There were 70 patients with Ebola, and it's me and one other guy. And of course, people are, it's not about starting intravenous therapy. It's about essentially just people asking, I need food, I need water. So we're really dealing with this situation that right now is a very rustic, difficult one, and trying to get this together and trying to get the resources to do a much better job of what we, and do what we want to do, not what we are forced to do at this point. So, I mentioned this a little bit. I don't have time in front of me. Is there a clock somewhere? Just so, guess not. Okay, so I have 20 minutes? Good. What do we usually do? We usually have these intense, relatively short 2, 3, 4 month efforts and things like that. And the last month is usually kind of just sort of doing some basic surveillance and make sure that that cases don't come in. And we set up case finding and isolation and treatment units. This is not rocket science. It's classic epi principles and what we normally do. And so you have a case of Ebola, you set up a treatment and isolation unit, you find that person, you try to get them in, give them the best care that they can, and also get them out of circulation, of course, so they don't infect other people. But then each place that you have a case, you need that care providing center, but then you need a surveillance team to go trace contacts and do case finding of other people who might be sick. Then you need a social mobilization team and a communication team to get the word out to the community. Then you need a burial team, and all these people, you need a laboratory team to get laboratory diagnostics. They all need transport, right? If you need to go do surveillance in this village, that village, and often over some rough roads and distant places. And so when you think about it, the analogy, well, using a military analogy, so you have this one front, and you say, okay, we're fighting on this front in Gekidu, and now there's cases in Conakry, 600 kilometers away. Okay, well, we can do that in Conakry too, but now there's cases in Kailahun, Sierra Leone, and now there's cases in Kenema, Sierra Leone, and now there's cases in Monrovia and Bong County, and so you would go on, each place is a new front, and so you can imagine how we just outstrip the resources to really wage the battle in all those different places, and that's what we've been faced with. So we normally would do daily tracing of contacts. I'm sure you're all familiar with this conceptually. It's not particularly difficult. You go and find those people every day after their last contact with the case. You ask them how they feel. Sometimes we try to see if we can take the temperature, if the capacity allows it. And if they say fine and don't have a temperature, don't have a fever, then we say, great, you don't have Ebola today, and we'll come back and see you tomorrow. And if we come back for 21 days in succession and they never feel sick, then we say you don't have Ebola and have a nice life. And if they say I have a fever and headache, then we try to bring them into an isolation ward. So we can do that as long as we don't have too many contacts to trace. And then all this goes in the education and social mobilization is the context there underneath it all. And so this is what we had where it was percolating along in Guinea and then got into Sierra Leone and Liberia. And then we have in recent months this exponential spread and things really just going, getting out of hand. And you can visualize that in a fairly easy way where you have, if we have a reproduction number of, let's say, around 2, although it's a little less than that. So you have one case and that begets 2 cases, and each of those cases 2, and then 2 and 2 and 2. And so we get into this sort of exponential type numbers. So why won't that work now? I've mentioned most of this. The scale has really just outstripped what we were prepared for and the multi-country nature. What do we need to do now? We need to have a massive upscaling of all elements. We're late. There's no doubt that we're late in doing this. When we had this outbreak, again, recognizing in around June, July, that this was really getting out of hand, WHO called a meeting in Ghana, I think it was maybe in May or June, to try to sound the alarm bell, if you will. Some countries have responded faster, some countries slower. Now I think we are getting a response. It's definitely late. It's challenging, of course, because even though the money's part of it, the money's important. And have you seen Mark Zuckerberg gave $25 million to CDC 2 days ago? Gates Foundation gave $50 million to WHO. The World Bank, $100 million. So things are happening. But the analogy that I use, it's sort of like I say, okay, we need to put a man on the moon tomorrow. And then you might say, well, it costs $7 billion. And even if I say, there's the $7 billion, we have the money, we're still probably not going to have a man on the moon tomorrow because there are just logistical impediments, the real-world impediments of doing that. We don't have the rocket ship to just come out. It takes safety issues, it takes training, it takes planning and all these things. And we don't have the capacity, we don't have any ready-made capacity in the world to do this. If this was a military operation, we know how to do that, right? We can place 1,500 troops or 15,000 troops somewhere relatively readily. And we know that they have ammunition and they have weapons and they have logistics and all sorts of things that we know how to put in place. But there's no standing ready capacity to do this for a large filovirus outbreak. So this is uncharted territories for us, and we're trying to catch up. I won't go into too much detail of this. We need to basically decentralize in a way that's not very comfortable, so this can no longer be in much of West Africa an individual type approach, and so we're never going to be able to trace all the contacts of 20,000 cases in Liberia, and so we need to probably use proxies that are Again, not very comfortable because we're going to say, this village we have evidence of infection here, and this village we don't. And our mission right now is just to prevent the virus getting from that village to that village. And again, that doesn't feel very good because we're not necessarily doing anything to protect the given individual in one village. That's not what I want to do. That's not what we'd like to be doing, but that's just our choice right now with the capacity that we have. And then we hope to be able to get back to a more individual approach if we can catch up. Travel restrictions, obviously you guys are probably, this is one of the things that's in the forefront of your mind. There are different ways of thinking about this. I do think it is a mistake to have just drastic travel restrictions where we say, well, why don't we just stop all the travel from West Africa to the United States and we'll never have any imported cases. That would probably be true, but we have to recognize that there are severe consequences on both sides of the Atlantic for this. First of all, I personally would appeal just to start with on a humanitarian level. I'm not comfortable just saying, well, terrible things are happening in West Africa, and let's just make sure we don't have a problem here in the United States. I don't think that's what we're about or what we want to be about. And second of all, we are linked in ways that we don't necessarily realize. I think you're all conceptually aware of this, but there are a lot of things that happen. If we stop that travel, we first of all, we can't get people into the country to try and put out this fire. We can't, there's huge economic ramifications for that. How many, I'm not a big diamond buyer myself, but how many diamonds come from Sierra Leone? So the diamonds don't come from Sierra Leone anymore. What's the ramifications on that in Brussels? And what's the ramifications after that in New York? And so we're linked in many ways that whether we like it or not. And I think the answer is not to say when we have a raging forest fire over 2 blocks away, the answer is not to say, well, I'm going to stand here with my bucket. We need to go to the forest fire and we need to put it out there. And that's in their best interest, but that's in our best interest too. So, and then to accelerate some of the experimental therapies and vaccines, I'm going to go through this briefly because I want to leave some time for questions. And I think there are some particular issues you'd like to get into. This is just some of the things we've been going through on the science side and public health implementation side with WHO, trying to figure out some of these transmission studies. One of the things that's not really worked out amazingly is we don't have studies where we've just taken samples from somebody at every stage of the disease and say, okay, and what exact tissue, at what period of the illness, and how much virus is there as we go along. And part of that is because I won't say it's misguided, but I think it was maybe a little bit short-sighted. Our research program has been very product-oriented, and so we've said with select agents, what we want out of that is we want a vaccine or a treatment, or we want a diagnostic test. All important things, and we do have some advances in that level, but we really haven't said, we really want to understand more about this disease, and now we're really wishing we did understand a little bit more about this disease. We do know some things inferring from the epidemiology in the field, but we need to know more. There are lots of different questions about PPE or personal protective equipment, what works and what doesn't work. I think I mentioned, maybe not in this group, I can't remember, it's sometimes oversimplified and people saying, well, the PPE doesn't work because someone got infected. But the PPE comes along with a whole bunch of other issues. It comes along with training, comes along with environmental health. And so expecting to just give somebody PPE who doesn't have all the other benefits of the training, of the environmental sanitation, of having sanitation officers, of having lots of supervision and buddy systems and different things that they practice and understand how to do. It's sort of like telling a pilot, there's the plane, go fly the plane safely, but not worry about any mechanics or any support personnel or anyone to guide it down the runway. So it's not just a matter of kind of throwing materials at people. And we have some interesting things going on with Obama and USAID, the Ebola challenge to develop some new and better PPE. This is just to give you an environment of some of the remote places that we can see this. I was actually out there to try and find this little girl who was a contact of a case of Ebola who fortunately did not have any illness. But trying to get to all these places is a difficult thing. And so there are probably things even in these areas with cell phones and other means that we could probably push forward with some operational research. There are questions about the the genotyping, and this virus, probably the one that you're most familiar with in the news, is about the mutations that have been noted. There are different opinions. I think it's extremely unlikely, for example, that we would have something where this would become an airborne virus. I can't really think of any example where mutations fundamentally change the biology of an organism, so it's transmitted in a different way. Mutations can be important on different levels in terms of whether the diagnostics that use primers and probes would still work, some of the medications that we hope to use in the future, whether they would still work. So it's something we need to follow, but I don't think it's as dramatic as talking about whether we're going to have airborne spread of this virus. I think there's not a precedent for that or a reason to particularly postulate that it would happen. Animal models, most of what we know about this disease is from doing this experiments in monkeys. It's very difficult to study people in the field. Of course, we can't do a lot of prospective research in this virus and say, okay, let's set up an Ebola project, for a year from now, write a grant, and a year and a half later we'll start. So a lot of challenges there. Briefly, just give you an idea, a lot of different experimental therapeutics that are out there. Some of them have safety data, some of them have some efficacy data in in non-human primates. We don't have any that really have the full gamut of safety and efficacy data in humans. Some of them have gone into accelerated testing in recent weeks. So we hope to have some of these products later on if they look good. I think this is not going to be our way out of this outbreak. We hope to have these things. And I do, as grim as the situation may seem right now, one of the things that I hope will be the silver lining of this is that we are going to come out of this with some real world tools, hopefully in time for this outbreak, but if not now, for the next outbreak, where we've gone through and developed some vaccines, developed some therapies, developed better PPE, developed some approaches that even if it doesn't have an effect here, can do that in the future. Same with vaccine. I'm sorry, this is immunomodulators. We'll skip that. But vaccines, this is just the two most promising and most developed ones right now, which are presently in phase 1 safety trials in humans. We hope in a month or so to have those data. If everything looks good, then we go forward with some accelerated phase 2 trials where we understand a little bit more of the dosing. And in the meantime, people are ramping up the production of these vaccines. We hope by the new year to have maybe 10 or 20,000 of these doses of these vaccines. And if they look good, then we would have some tool at least. We haven't figured out what we would do with those yet, but the presumed target would be healthcare workers, and to give those to people who are going into the field and taking care of patients. I already went over those, so a couple last slides. Our biggest impediment, in my opinion, of this is the labor. And so if we think, although I'm supportive of the Obama plan, but our challenge when we say we're going to train 500 people a week, where do those 500 people come from? So picture in Liberia, where the medical school was closed during the war and then reopened a few years later, but graduates an average of 10 or 15 people a year. So we have 10 or 15 doctors a year who come out of the medical school. I would speculate that maybe a third of them are already drawn off by the brain drain and working elsewhere for a little bit more money. And there's some estimates that 20% of the healthcare workers in Liberia have already died of Ebola. So when you think of how many healthcare workers do we have, how many doctors, there are probably more nurses, but not that many more. So a big challenge, and I can tell you when you're in West Africa and trying to train and recruit people, and saying, okay, how many people want to do this? There's not a lot of hands going up, right? Especially when they recognize that one of the reasons that you're training and recruiting people is because their predecessors died. So a big challenge. And then the United States, we have some people who are doing this. We had the first training conducted by CDC, and it was actually in Anniston, Alabama, where there's a FEMA Homeland Security training site. And so we were down there a few weeks ago, and that's ongoing training people from the United States. And we have some public health service physicians and some DOD people who are getting trained to try and staff what we're trying to do in Liberia and putting up these 1,700 bed, 1,100 bed units. And so, that's the right thing to do, but the implementation is just really challenging. And when you think, not pointing any fingers, but you go around this room of healthcare workers, and first of all, I say, how many people want to go? There's a lot of people who won't want to go, and I can understand that. And maybe 90% will say, no, I would never do that. And 10% might say, well, I would do it, but my husband or wife wouldn't really be enthusiastic, or I have kids to take care of. And then the 5% who say, yeah, my husband or my wife gave me the green light, but my department chair is asking who's going to cover my patients during that time, and the dean's not really happy with me doing it. And so, we whittle this down to a small number. So the labor is really one of our biggest challenges. And so that means that ultimately we have to employ relatively unskilled labor. These are people going through a training in West Africa and Guinea, not for clinical care, but for surveillance. And we're going to have to count on these people in the long run. And that's not an easy thing to do. And what it challenges us to do is take what we would normally consider sort of long-term development and compress it into something that we need to do over a short period of time. And as you all know, it's challenging enough to do that sort of development work when you're talking we're going to do it over 5 years or 10 years. And now you say we need to do it over the next 3 or 4 months. We have a lot of challenges. And I think I'll end with this. For me, working in this field, the last, I don't know how many months it's been, but there's an incredible interest, of course, and one of the things that happened, there's tons of media interest, and I get calls. I could do 5 or 6 interviews a day, and you get real popular real fast. But I want to remember, or make sure that we remember people like this. So it's pretty easy for someone like me, relative. I go into the field and then I can come home and I can try to catch up a little bit. These people, they never get out of it. It's their community, it's their hospital, it's their family, it's their life. And some of them have really paid the price through this process. And I think we need to remember that. Maybe I will still make a few last comments, because I'm sure what one of the listeners already brought up, I'm sure you guys want to hear about what's going on here in the United States. And so I guess I will point out that, first of all, this is my opinion. It doesn't represent CDC, WHO, anybody else. This is just how I see the situation. Obviously, I think it's valid. So if you went back 3 or 4 weeks ago, if you listened to what President Obama or Tom Frieden, the CDC director, or other people said might happen in the United States, that we said, and including myself, that with the magnitude of what's happening in West Africa, that it's entirely possible that we could have some imported cases here in the United States. And as you all know, we've had an imported case. And it's entirely possible, albeit tragic, that we could have some degree of secondary transmission. As you know, we've had 2 cases of secondary transmission in the nurses in Texas. So I don't think what that's been interpreted often lately for me is that just this incredible misjudging of that, of what we see now, and people saying, well, we have this huge Ebola problem in the United States. We do have an Ebola problem in the United States. Obviously, it's tragic for these individuals who have gotten here, and we need to be concerned about that, and we need to be vigilant about people coming into the United States from the epidemic areas. Again, I would not advocate that we stop all travel, but we need to have a system as effectively as we can to monitor people who have symptoms that are consistent with Ebola virus disease. Isolate those people. And obviously, I think, we can all recognize from the outside some errors were made in Texas, and things didn't go how we wanted it to go. And so we need to reevaluate a little bit. I got a call last night from CDC about developing a SWAT team, if you will, of experts that would go to places where this might come up. I think there's a strategy afoot to perhaps try to collect patients rather than put them in every hospital where they might show up, to transfer them to a few centers in the United States where they may have that expertise and the opportunity to have more training. So is this something that, in my opinion, we need to respond to? Yes, we need to respond. Of course, we need to be prepared. Most people here are, probably somewhat in the domain of public health, and we recognize that we can't be naive about this. We can't say we're going to set up an Ebola virus treatment center in every hospital in the United States. We have no way of training every individual person. We need to find that sweet spot, if you will, of preparation for what we can do, but not panic and not an incredible expenditure of resources that we don't have for something. It's still the case. I do not believe that we will have a large outbreak of hemorrhagic fever in the United States. We have gloves, we have gowns, we have the public health system, we have water, we have soap, we have needles that are clean. So will we have another imported case? I think that, perhaps we will. I can't really get my crystal ball out to tell you. Is it possible there would be secondary transmission on a limited degree from an imported case? That is also possible. But I don't think that we will have, hundreds or thousands of cases of Ebola virus here in the United States. I think we have the capacity, the public health system, and the technology basically to avoid that. So, that's the message that I want people to take home, I think, or two messages. One, as I said earlier, we do have to focus on putting out the fire over there and not get so inward in the way that we look at this that we forget about that, and that's not in anyone's best interest. And then and then we need to keep the science-based. We know some things about this virus, and we need to remember that, and we can't let some of the non-science and the things that are swirling around us kind of take us away. So I will stop there and entertain any questions. Thank you.
Can you use the microphone to answer your question?
Hi, thank you for this talk. My name is Sarah Fargo. I'm a pediatric infectious disease attending here at Rainbow. So my question, I guess, is twofold. First is reading a recent New England Journal article that came out from the WHO working unit for the Ebola virus. It seems like just reading the detailed clinical descriptions of the patients that were affected with the disease, the mortality and clinical symptoms are not much different from prior outbreaks. Prior outbreaks, however, were self-limiting. And so is there anything inherent to this particular virus that's causing this epidemic? If not, is this all secondary to lack of international aid and international response? And if that's the case, can you put in more abstract numbers for us what you think needs to be done in terms of ETUs, Ebola treatment units, or human resources, and what can we do for those of us who have spouses and children and do not necessarily, and are in the public health domain and will not be going to these areas?
Right.
What can be done from our standpoint?
Right. Okay, two good questions. Thanks. The first one, in terms of the clinical presentation, we don't have, it's very rare to have from any Ebola outbreak where we have very detailed charting and the evolution of the disease. I do think that clinical presentation is very similar to other outbreaks. However, my impression, again, I don't have data to show this, my impression is that the volume depletion, the amount of diarrhea that these people are having is really excessive and more than I've seen in other outbreaks. And so I wonder if that's one factor. Of course, by the time people develop that diarrhea, that's probably a very infectious, high virus load in that substance, and they're having, of course, lots of copious diarrhea, almost in a cholera type way, if you've ever seen cases of cholera or are familiar with that. So that may have something to do with why we're seeing, such a big outbreak. But I ultimately don't think that the answer is as much biological as just social and political. And we've got into this area where, again, as I mentioned, the countries themselves are really unprepared given their history. And I'm not a person who can give you numbers on the economics, but I think just looking at what's happened over recent years due to the global economy, I think that we are relatively unprepared, and we've slipped back a little bit in terms of our investment in global health and tropical medicine, and looking, for example, at WHO. Again, I don't know the numbers, but having collaborated with them for a long time, years back I would be at WHO, and it was kind of a bustling place, and there'd be two people sharing an office, and in more recent years you've gone and it seemed pretty quiet. There were not that many people around. So I think there is some degree of that we were caught a little bit, and it's always the struggle in public health, right? And when things are when public health is working right, things are quiet, and then the people who control the money say, well, why would we invest in that, right? Because, there's nothing going on. So we have that a little bit, that paradox. I think your second question was specifically kind of what do we do? I wish I had the very specific answer and say, we need to change this or change that. I think we still need to increase that upscaling. We need to go along the path that we're going. We'll get to the moon, but it's too late. And all we can do is do it as fast as we can. I didn't want to put up for this group. There are different places where you can donate to. I realize that not everybody is in a position to be able to go to West Africa and help directly. I would say, and I can give you information about, and you can pick your choice of MSF or the Red Cross, or I'll give a plug for an NGO that I work with called Doctors for Global Health, and many different places that you can donate. But I also want to come back to there's that message that we really, I do feel that it's not infrequent that some of the panic, some of the misinformation that comes around from and comes about with this virus, unfortunately comes also from the medical community. And I don't necessarily find that, there are scientists. There's going to be differences of opinions, and we won't mention any names, and people can differ with me, and that's just the way the process works. But nevertheless, we need to count on everybody in a room like this, and count on the scientists. You're the people that have to keep this science based, and that kind of, because if you panic, then who do you look to, right? So we're at this sort of bridge point in the United States, right, where people are starting to panic and say, terrible things are going to happen. I don't think that's true. You can all make your own determination about that, but since you have that background, since you invested all that money in medical school, you use that to make sure that your opinion of this is science-based, and let's try to, be the rocks in the community about that, and not be the people who are going to kind of accelerate that panic. So I know that's not a very specific answer, and there is no easy answer that I have, at least.
We have time for one more quick question.
Okay.
On your map showing the distribution of the disease, I was kind of curious about when you hear of the news starting up with this, it was coming out of like Conakry and Monrovia. And so my impression was that you probably had urban outbreak. But you got a large spread on that. And I'm wondering, of these thousands of cases through this geographic area, are they concentrated in urban areas, or do you have multiple foci? And then what would be the attack rate in a given village and so on of this disease?
So yeah, it is spread, unfortunately disseminated. Monrovia has lots and lots of Monrovia is a city of about 1 million plus, which has lots of Ebola virus sprinkled around in an urban area. There's also lots of Ebola virus in rural areas. So really, it is not completely homogeneous if we looked at the map, and there are areas of the country where there's a lot more, and there are a few of those districts that were colored in where there are relatively few cases, but there are certainly thousands of cases of Ebola in Monrovia, and then other rural districts where there are also thousands of cases. And so that's one of our challenges, and brings me to a point that I didn't have time to get to, but I'll just take a minute here. One of our real challenges when I described that public health approach, of course, it's all predicated on collaboration with the community. So the community has to be willing to say, okay, I'm a contact and come see me every day, or I feel sick and put me in an isolation and treatment center. And we've had a big problem with that, and you've probably read a little bit about that, and some healthcare workers who were killed in Guinea a few weeks ago, and I could tell some stories of some tense moments in Guinea and Sierra Leone. I think everyone who is there can tell those stories. And so that's a real problem where rather than people wanting to come to recognition and then us being able to implement that sort of public health approach, if they're hiding, if they're staying at home, then it's very difficult. And it's easy for us to judge and say, you know, how stupid are these people for doing that? But I want to point out that, you know, if we look into the background of this, the colonial era in sub-Saharan Africa is only about 50 years old. And so for centuries before that, people who looked like me came to different places in sub-Saharan Africa and said, we're here for your best interest, trust us, and that wasn't always so true. And then when the colonial powers left and gave way, they often gave way to very ineffectual, corrupt governments that really were the seeds of the civil wars in Sierra Leone and Liberia, and the president of Liberia is in prison in The Hague for human rights abuses. And so even though it seems very foreign to us, when you think about it from that history, from that vantage point, it's not illogical at all that someone in a village in Sierra Leone or Liberia, when people come in and say there's this thing called Ebola, it's not illogical at all for them to think, well, maybe we shouldn't trust this person. So that's a huge impediment. And I think you had one more aspect of the question. Did I cover it all, or there was...
Yeah, I think pretty well. But this current New England Journal on the web at the moment has a film from the Congo, which apparently they have an outbreak going on right now also.
Right.
And I think the number was something like 50 or 60 cases, but apparently the curve is on its way down.
Yeah.
So when you come into figuring, and they're in very rural areas, so you get a good feeling for that with the film as to what the logistics are.
Right.
But I was wondering, why would they be able to cut this off after 50 or 60 cases where that wasn't possible in these other countries? Various different things. I mean, the Congo's had numerous Ebola outbreaks before, and so they have people who are more familiar with it. And they don't have some of those cross-border issues and don't have some of the proximity to the large urban areas where you can get relatively readily. So I'll stop there. Thank you very much.
Thank you. Dr. Bausch, thank you for such an important perspective on such a critical issue. I think you've brought up a critical aspect for us at an academic center and as physicians, that one of the things that drives many of us in this atmosphere is fear. And the antidote to fear is information. And I appreciate all you coming here to get the best information from one of the world's best experts. But I would also say, echo Dr. Bausch's position that more work in epidemiology, more work in the basic virology, more work in the immune response to these diseases is really critical. And this is really an example of why you work hard in your labs, why the folks at Tulane and Dr. Bausch are working all the time, why Jim's group and Chris King and Pete Zimmerman and Brian Grimberg are working so hard to elucidate the basic biology, the mechanisms of spread, and look at interventions. So I encourage you to tell that to your congressman. Thank you again, Dr. Bausch, for your time and insight.